Thank you for that introduction. So the nature of my work, I am embedded in the Department of Mental Health and Addiction Services. I oversee opioid services. I like to describe myself as overseeing all the projects that are new. We have a SOTA that also oversees a lot of opioid work, especially related to the OTPs or opioid treatment programs, which we do in Connecticut have a robust system of OTPs, and that they have been around for many years. I don't oversee those. I oversee all the things that are new. So new meaning the grants that started coming since 2016, the federal grants related to opioid work, starting with MEDEX, STR, State Targeted Response, SOAR, State Opioid Response, and now overseeing the project and the administration of the settlement money. And so I've been doing this work for I've been working for the Department of Mental Health and Addiction Services for 11 years, and the last 7 years I've been focused on the opioid work specifically. What else can I say? I've been in the field for probably around 20 years or so, working as a family therapist before coming to the state. And also working in a women's program that addressed addiction. So that program was an outpatient IOP program. That was a very fun part of my career, I would like to say. I do enjoy women's work, working with women and for women and with women. So just wanted to mention that. I think that's enough for now.
Did you grow up in Connecticut?
I did not grow up in Connecticut. I grew up in Poland. And I moved here as a teenager.
Poland?
Poland. Not Poland, Maine.
Not Poland, Maine.
No, Poland, like the country.
I did not know that. I'm glad I asked the question. Dee.
Thank you. So I am from Southern California, came to New England to get my graduate degree, and I've been here now 32 years. So I'm an LICSW, and I started in the field here in Massachusetts working with women at the intersection of addiction and sex trafficking and homelessness. And it was like a duck to water. I found home. Right? And I really, really loved it. Since then, I have worked in methadone programs at what we call Mass and Cass, which is a large area of unhoused drug activity in the Boston area. Run residential facilities, co-occurring disorder programs, and Suboxone programs. And about 7 years ago, in the midst of the opioid crisis in Boston, I was fortunate to work at a program that our then governor, Governor Baker, and Mary Lou Sutters, our Secretary of Executive Office of Health and Human Services, came to visit. And I was mad. I was like, why is everybody overdosing? Why can't I get anybody into treatment? Why is the insurance, not covering? And basically they said, if you think you can do it better, you can come work at the Bureau of Addiction Services. So I applied, and to my shock, I got a state job, and I had no background in state work. I am a clinician, and I am the first clinician that's ever been in this position, which I think has brought a lot of different perspectives and a different view and a different, I think, personality to this. I think so I've been with the state for 6.5 years, and our bureau is the single state authority for Massachusetts in anything prevention, harm reduction, treatment, recovery, support services, anything that touches addiction in the state of Massachusetts falls through our bureau. I have our wonderful Soda who's here, who oversees our OTP programs. And then the only other thing I would say is that I think the other thing that I bring to this work is that I am only the second person that is in long-term recovery that has been in this position as well, which also brings a different flavor to it. Nothing about us without us.
The second person wasn't Botticelli. He was in a different position.
It was Michael Botticelli. He was the first.
Yeah. Well, he's a favorite of ours as well.
He's a favorite of mine, a good mentor of mine.
He has keynoted this summit probably 5 years ago. Thank you for that, Dee. Cathy, Rhode Island.
So, hi, everybody. I always speak from the heart, and I have more talking points than probably everybody sitting here, but I probably won't read any of them except some data later on. So my name is Cathy Schultz. I'm the director of the Governor's Overdose Taskforce. I, more importantly, am a person in recovery, but I'm also a harm reductionist. I'm formerly incarcerated. I'm all the things. So shout out to the state of Rhode Island for hiring a felon. And that's stigmatizing language. I'm calling myself that. I just want to make sure that we don't walk around and call people felons. So I actually came into this work. I've been in recovery for over 21 years. And in about 2014, 2015, I had some newer folks that were coming into recovery that I was mentoring in my personal pathway to recovery. And I just started seeing everybody kind of doing die-outs on the State House lawn. I started to see obituaries of my friends dying, like one after another. And I was curious, but I wasn't ready to get into the field. Some life things happened. I had a child at 39, and I decided that I wanted to change my career and go back to school. So I took some time off, went back to work, took a probably $20,000 a year pay cut, and became an outreach worker. Because I firmly believe in order to do this work, you have to be boots on the ground. You have to literally be going to encampments. You have to literally be out there, front line, to understand what's happening out there on the street. So bringing us back to now, I did that work for a while. I started to do some local community macro work, changed my major 20 times. I even went to BU, by the way. I was going to get my social work, and I decided to just get my MPH because I wanted to look at the whole picture, and I wanted to be very broad. I got my degree a few years ago because I raised my kids and stuff like that. And I started actually at the Department of Health in the state as the project manager for all of the harm reduction and mobile outreach efforts, including all of the naloxone distribution. So I've created for the state of Rhode Island a lot of the centralized naloxone distribution across the state. We had some major harm reduction efforts, including helping to write the regulations for the Overdose Prevention Center, or you might know it as the legislation, which is the Harm Reduction Center. And this position opened, ironically, because of a walkout at the governor's task force, because the community got really upset with the state. They walked out. I worked for the state, so I had to stay. But I did tell the Department of Health, BHDDH, everybody that, the community is trying to tell you something. And they put this position, they did a new executive order for the task force, and they added a director of the task force. And I applied, and here I am. So I am kind of not sitting in the governor's office, and I'm not you, Gordon. But my job is to do what Gordon does here in the state of Maine, and that is to bring all the state agencies together and kind of bring you all to the table and just ensure that we're following our strategic plan. Thank you.
You do a great job, Cathy. And as you know, I try to join by Zoom their monthly Overdose Task Force meetings, which was yesterday. And Cathy's responsible for those meetings, and I'll tell you, we'll get into this a little bit, but one of the things that I'm really jealous of is they have and I don't mean to suggest that we don't have great people trying to do what they can on data, but they've got a data team there, some of them from Brown, some of them work for the state, but they just, and we all say, we want to be data driven, but we've got a lot of gaps in data, and this is true across the country. I'm not just talking about Maine. We have a great data team at the university, and we have great data on fatal overdoses. Boy, once you expand beyond that, particularly treatment, we talked about this last night at the fireside chat, that, to try to get good data, outcomes data from let's say your loved one is trying to get into treatment and you want to take a look at residential treatment in this country or in this state, it's a real challenge to find out, get good quality data from our treatment programs. My next question of all three of you, really, if you were, pretend we're not here and you're doing a media interview today with one of your local television stations in your state, and they say, how are we doing in Connecticut? What's the current state of your work? Are you seeing a decline in overdoses? How do you feel about the situation in Connecticut today? And then we'll go to Massachusetts and Rhode Island. We'll start with you again, Luiza.
Thanks, Gordon. So Connecticut's definitely in a decline. It's been in the decline for consecutive 3 years. We did have a peak in 2021. Last year, we had a 26% decline. The overall decline from that peak in 2021 is about a third. And I think very similarly to Maine and other New England states, we have several buckets where we have prioritized our initiatives, and those are the prevention, harm reduction, treatment, and the recovery support buckets. And we've heard about naloxone distribution, harm reduction efforts, outreach efforts. I think all of those are very important, and some of that invisible work that Dr. Dasgupta was talking about that we are maybe not showcasing in our data. But yes, the data is certainly showing a decline as the other New England states.
Dee.
Yes, so we are also in a decline. It's our second year. This is our biggest decline. So we had 36.3% in Massachusetts for the year 2024. So I just feel incredibly grateful to live in Massachusetts. Even our last governor, Governor Baker, he was a Republican, but I think in any other state he would have been a Democrat. And so he was able to hear and kind of see the value in harm reduction. And so even though I'm so grateful to live there, we should be having overdose prevention centers where, we are always constantly fighting with our New England neighbors wanting to be the best at something, whether it's, baseball teams or that, and that Rhode Island got an overdose prevention center before us is just really infuriating, but they did. So I think that we could do that more. But the things that we do really well, we've handed out, hundreds and hundreds of thousands of naloxone. We exceed the naloxone saturation requirements, tenfold. Don't quote me, but a lot. Our fentanyl test strips, over 500,000 of fentanyl test strips. We provide safe smoking supplies. We have outreach. We have over 50 OTPs. We have harm reduction vending machines. We are doing everything in our power. We have every lever that we can possibly legally provide, we have done. So that is, amazing, and we really hope to continue seeing a decline. But we're in the same boat as Dr. Dasgupta has said, is that it really is the supply, and I get a little frustrated when people say, "Well, what did you do differently?" It's not like I'm withholding the best thing that I'm going to do behind my back and say, "Well, I'll bring that out when it's really bad." We are doing everything, right? Like there's nothing I'm withholding that I can legally we're doing everything. So sometimes it's not what we're doing or what we're not doing. It's the drug supply, it's behaviors, it's all of those things.
Cathy. Yeah, it's already on.
It's on, okay. So in Rhode Island, we are also seeing a decline. It's our second year of seeing decline. We're at our peak in 2022, and we had a pretty significant reduction in 2019. So it was really upsetting for the community, for everybody that was involved. We have seen the last 2 years a decline, and as of right now, we had a 25% decrease from our peak year, which was 2022. In Rhode Island, we also set a goal because when I came into this position, we had always had a goal, but it kind of, everything changed and everything was on the increase. So we set a 2030 goal of reducing fatal overdoses by 30%. Back to compared from 2022, bringing us below the 2019 numbers that we were at, and we're already at 25%. So we're seeing that it's working, and that the work that we're doing is working. And like my colleagues, by the way, you have safe spots. We don't. So, and we're talking about it. But anyway, but as my neighboring states, Connecticut and Massachusetts, we have a strategic plan, and it kind of sounds like we all have the same pillars. It's prevention, because we want to do primary prevention, secondary, all of that. We want to try to prevent overdoses. We want to try to prevent youth from using substances. We have harm reduction and rescue. In Rhode Island, we have very, very small, remember, so we get 50,000 kits free from Teva, and we are surpassing all 50,000 kits are getting out in the community. So we've also have some research studies that have showing that we are saturating our communities. Weight treatment, we have, I don't know how many off the top of my head for OTPs, but we have several. We have them in every single region. They're on bus lines. They're accessible. We are not concerned that we don't have enough. We've increased about 50 beds in our state for residential treatment and recovery. We are continuously supporting recovery and adding more recovery beds in our system. But we still have work to do, and we know that. And I think it's really important, and I'll end with this, is that I know I'm saying numbers and I know I'm saying percentages, but every single number, all of these percentages are a person. They're a person that loved, and I always throw personal stories. Like my son lost one of his closest friends just last weekend. So even with everything we're doing and we're trying to do the right thing, like Dee said, nobody's holding anything back. We're doing everything in our power, but it's still impacting people that we love.
Do any of you think that you have enough residential treatment beds? Cathy says no. Dee says no. Luiza?
So there will never be enough because
Right.
they get filled. And so then
Right.
what we do, however, have is a core report, which is the Connecticut Opioid Response, kind of like a strategic plan with priorities. And what I like about that report is that it has some do's and don'ts in terms of settlement funding, recommendations for what works, what doesn't work, with lots of research by Dr. Filene and Dr. Howell from Yale University. And increasing residential beds is actually on a do not fund list in that core report. So, and I think Dr. Dasgupta also had that slide showing that, the risk increases for folks when they're in residential beds, coming out of the residential beds. They're just not indicated for opioid use disorder. So I think that's a complicated question, but I think the community, that's the first thing they tell us, is that there aren't enough beds, that they're struggling to find beds. But I do point them to that core report because there is some research that indicates that it's just not the best use of settlement dollars, and it's just not the best recommendation for folks who are seeking treatment.
It's interesting. Dee or Cathy, you want to comment on your residential beds?
Yeah, so mine is a little bit more moderate, is that, we also see actually increase in overdose deaths with people leaving residential, which also leads me to believe that sometimes we push people off a cliff. It's like after an amount of time, I have a sister who's very disabled, and her care does not end when a certain service ends. She's got people following her for the rest of her life, right? But in this field, it's like, 10 days in detox, good, see you later, 2 months in this. What we do need, and which we have better outcome data for is co-occurring capable or co-occurring enhanced residential facilities, which are much smaller census and much more integrated, because we're also not taking care of the full person in residential facilities. We've got the wound care, medical complexities, and aging population, substance use disorder, complex polysubstance use, and we're not capable of taking care of people in our regular residential, which tend to be much larger, 48 people in these beds, and again, no follow-up care. So agree that our outcome data is much worse for residential. I think the co-occurring capable and enhanced is where we need to spend some money. You have a question about one of the things we want to highlight, and one of mine is the low threshold housing, which I'll talk a little bit about because that's been a real crown jewel for us.
Cathy.
I actually just want to hear about the low threshold housing. No. So that's actually what I was going to say is like, so I'm not going to say we don't have enough beds, because I'm actually a person who went to treatment and was in a residential treatment, but it was so many years ago. I was able to stay a lot longer. And that was actually where my foundation came from. I was also able to sift through the continuum of care and go into a recovery house from there, and that saved my life. That's where my recovery journey started, and I was able to get that community. And this is before we were paying like we do for all this stuff. And it's just because I'm old that I have a different experience. Fentanyl wasn't here either. What I would say in our state, what we lack is women's. We did add women's beds, but treatment for pregnant women, residential treatment for pregnant women, long-term with the child, women and children, or parents and children, fathers with children, and low threshold housing, meeting people where they're at, even for people who use drugs. Because the reality is, as Dee said, if we're forcing people to make a decision to have a roof over their head and they have to stop using drugs and they're not ready, they're going to use drugs and they potentially could die. So we need low threshold housing. So can't wait to hear more about that.
Yeah, I think I'll skip the next question, go on to that question about one or two programs or activities in your state that you think that you're really proud of, that you think we could learn from. And we'll start with you, Luiza, and then we'll come right down the line again.
So I will not talk about our housing first model because Dee will talk about hers. But also very excited to have an approved recommendation from the settlement for low barrier housing, which I think will help a lot of people. I am quite proud of our media campaign. We started it in 2018. It's called Live Loud. You can check it out at liveloud.org. And in the last year, we have come up with several videos that are targeting a lot of different people. They're kind of animated. Red is the name of the character, and he's really cool. He looks like everybody and none of us. So I do appreciate animation for that reason. You can really speak to a lot of different folks. So that anti-stigma campaign is really important to me because I think stigma continues to just be such a barrier. And I spoke about the core report, which highlights all of our priorities for the state. That's also a document that's worth looking at if you're interested. And then one thing I can talk about is our OTPs at the Department of Corrections. So the Department of Corrections in Connecticut has done a lot of work for years now, licensing opioid treatment programs right in their facilities. The last I heard, I believe, were 9 out of 13. All 13 facilities in Connecticut have access to medications for opioid use disorder for individuals who are incarcerated. But I believe 9 out of the 13 are actually functioning as OTPs in our state, which I think is great. I'll stop there.
I didn't write down all of our programs in carceral settings, which we also do. So the there's three things that I just wanted to, that I'm really, really proud of. There's so many things. It's hard to, it's like Sophie's Choice. What do you pick that's really good? So we have the START programs, which are stimulant-based outpatient programs. We have one down at the Mass and Cass Boston area, and we just had a procurement where 3 more came in, which is using contingency management, MOUD, and others to really focus on those with stimulant use disorder. And I encourage you to go to mass.gov and look it up. But our low threshold housing in 2020, we really made a concerted effort to do some housing first, where sobriety and abstinence is not a requirement for housing. As we know, many of our folks, we're teaching a whole generation of people how to lie, because if you raise your hands and ask for help, you lose your kids, you lose your housing, you lose your car, you lose your job. So I'm gonna lie, right? And so if they're in housing and they transiently use or are hanging out with somebody, they're gonna lose their housing. So we thought it was really important. We plagiarized heavily on the AIDS movement of housing first. And since 2021, we have permanently housed 650 individuals. We have a 94% success rate. We've only lost 2, yes, thank you. I agree. It's amazing. If we had more money, we would do more, right? And so, and they all come with 10 hours of intensive wraparound services. It also comes with harm reduction. Some of the sites that actually have harm reduction vending machines, wound kits, wound care. So the individuals there do not have to worry. And many of them, their use has gone down, their engagement has gone up. So we're really, really, really proud of our low threshold housing, and it's now built into our state appropriations. So we are going to be able to fund this. We also do it braided through our opiate remediation fund, which is what we call our settlement money. And the last thing I really want to highlight is in 2022, we were the first state to fund an overdose prevention hotline called Safe Spot, which is 24/7 access to people with lived and living experience for those individuals who are using alone, to have somebody on the line while they're using, and then stay on the line to ensure that they're safe. And once they determine that that person is safe, then they disconnect. So far, they've had, I think, 20,000 use calls, more than 20,000 use calls. They've responded to 23 overdoses. And it's just amazing. And it's become kind of the model for other states are coming into it. So I'm really proud of Safe Spot as the first state to do that. So those are the 3 that I'd highlight.
I want her a microphone so bad that I just keep looking at her like, give it to me. So before I talk about the Overdose Prevention Center, because I can't not talk about that, but I do want folks to know that Rhode Island has been doing a lot of things across all our pillars, like I said. We have increased our having student assistance counselors in our schools. It's not all 100%, but that's what we really wanted to do, and we did use our opioid settlement money as well as some of our prevention money from SAMHSA to do that. We have in treatment, like I said, we've increased a number of residential treatment beds, including for women, which we didn't have. We still have a lot more to do. We're actually borrowing the START program. Yesterday's Governor's Overdose Taskforce, we actually heard from Justin Elves, who is the START program in Massachusetts, and we have a procurement out there right now for that. We are also really trying to focus on youth residential treatment. We don't have enough of that. That's, truth, and we know that, so we have a procurement that's out there right now. And all these procurements are opioid settlement funded, and this is really for the brick and mortar part of it, because they are Medicaid reimbursable services. And then recovery, like I said earlier, we did increase recovery housing. But I know with all, drum roll, the Overdose Prevention Center is probably the most innovative thing that we in Rhode Island have done. In 2021, many of you may have read it, but I'll tell you anyway, legislation passed charging the Department of Health with developing regulations to pilot a harm reduction center, which is now what we call an overdose prevention center. I think it's important about the name, the reason we call it an overdose prevention center, because even in the regulations, that this center is not just about consuming substances, pre-obtained substances, which you can do. It is also to make sure that we have wraparound services in there. I want to make sure, and and note that Project Weber Renew did apply for funding through our opioid settlement committee. They did decide that we wanted to put a procurement out. And in 2022, that procurement went out. In 2023, we went into contract with Project Weber Renew, which is our largest harm reduction organization in the state, to open or fund an overdose prevention center. In January of this year, so about mid-January, the Overdose Prevention Center was provided, they were awarded a license by the Department of Health. It took us a couple of years, if Maine is ever interested, and you pass legislation, and you do it through the Department of Health. It will be a long process, I assure you, because it's brand new, but we're more than happy to give you any lessons learned along the way. And since that date, I want to share some data. There have been remember, Rhode Island's very small. There have been 2,916 visits. 14% of those were fentanyl use, 70% were crack use, 15% was meth use, 8% was cocaine use. And people can use, and keep in mind that this data, people can use multiple substances. So some of that if you add it up, it won't come to 100%. Of those, 460 were unique clients, 51% were white, 24% were black, 24 were Latino, 9 were Native American, and 65% of those folks were experiencing homelessness. And we asked them to break it down a little bit more. 10% are housed in their own place, and the rest are in shelters or couch surfing or in cars. So I knew, and I think we all knew what the population that were probably going to use this space, who those folks would be. So going back to, we need low threshold shelter, low threshold housing. And I also want to just report 51 overdoses. So that means 51 people were they were revived, and they are here today because of the Overdose Prevention Center, literally. And there were also 99 interventions that took place, which means in our Overdose Prevention Center, we have vamp rooms or over-amping rooms. So because of meth and crack and, all of the, as you could see, if you saw all the drug supply, they have rooms like cool down, chill out rooms in there. So they do count those as some interventions. There were a total of 99 interventions, which includes the overdoses and the overamps. EMS was only called once. And that's also important to note, that they are microdosing the naloxone, and they're using oxygen in order to revive folks, because we know that the drugs now, the supply is not just fentanyl, it's not just opioids, and it's really just about making sure that people are breathing. And then finally, the time frame is a little bit different because clinical takes a little bit longer to get that data. From the time they opened to 6:30, 211 unique individuals were connected directly to the in-house treatment center that is there. So there's an OTP right inside the Overdose Prevention Center. I also want to note that, and I think this is really important, this is the most cool thing to me, is that there are also showers. There's laundry. There is also the drop-in center. The harm reduction walk-in center is on the first floor of the Overdose Prevention Center. So people are able to get recovery supports, peer supports. They can even get trauma supports. And more importantly, the staff of the Overdose Prevention Center are also offered trauma supports, because sometimes they're people who use drugs or they're people who are in recovery, so they're impacted as well. So they're able to see a clinician as well. So sorry if I was long, but I wanted to give you all that information.
I've got a couple follow-up questions. So having visited the site just before it opened, the individuals that come in, they can have their drugs tested, checked, so to speak. Do you know what percentage of all the users had the drugs checked?
that would have to be a question for Project Weber New. I think that from my conversations with them, that they are actually, they have, like we've heard about fentanyl test strips and stuff like that. That's easily obtained in Rhode Island, but we don't want to just go by that. But I don't know the answer to that question, but I do know that they do have some drug checking there. I think that we want to get more drug checking there. The good news is they have a very, very intense client staff percentage. Like it's very, like literally one staff to each person that's in there. So they are very, very careful to make sure they're watching at all times.
Thank you. Dee, I wanted to follow up on something you said because people in the audience may not know that Safe Spot is coming to Maine. And they presented at the summit last year, and then the Maine Recovery Council gave them maybe $400,000. Procurement, you know, we wish that should be done by now, but I know the last time I looked in on it, it looked like that contract would be done in September. So by fall, they're already interviewing for positions in Maine. So we've had, Steve is no stranger to Maine, and we're really excited about it. You know, it's a pretty unique harm reduction strategy, and we're pretty excited about having them here. Moving on.
Connecticut is too. Yep.
Yeah, and I know they're talking to Vermont. I mean, we could end up having all the New England states except probably New Hampshire. So here's a little slightly different question. All four of us have been involved in our state work for between, you know, for quite a while. You know, maybe we average 8 or 10 years, 6.5 years in my case. What's been the biggest barrier to your work? What's been the thing that's most difficult that you struggle with? We'll go the other way so that Luiza doesn't always have to go first. I'd like to start because I got a long list, but I'll start with Cathy.
Oh, you start with me?
Yes. Okay. Greatest barrier.
The greatest barrier is stigma, and it's always stigma. It's always been stigma, and even when people think that they're not being stigmatizing, they are being stigmatizing, and it's really just because it's human nature. Unfortunately, I'm a stigma trainer. I do it on the side and professionally, and it was actually the project besides Housing First. I did 2 projects for my master's, so that is the biggest. So it's NIMBY communities in Rhode Island. Even though we're so small, our municipalities are so different from one border to another. It's really wild the way that we are. And I've never left Rhode Island. I didn't tell you my background. I've never left Rhode Island. Please help me. No, I'm kidding. I hope this isn't being recorded. Anyway,
it is actually,
I'm
Cathy.
But I've never left Rhode Island except for on vacation. So I'm through and through native, and each municipality is very different than the one next to it, and we call it counties, but we don't even have counties because we're small. Everything's one prison system, one Department of Health, one behavioral health, and it's that NIMBYism of some of the municipalities on very local levels that I think is the biggest barrier. There's many other things I can say, but very broadly, I think that's the number one thing that is a struggle, and it's painful, especially when you have lived experience and you're impacted, and you can't even put something on social media. You get people come out of the woodwork that just perpetuate, and with all good intentions, people will put things in with the good intentions. And I always say, you have to understand that when you use social media, like things can perpetuate stigma so quickly. So that's my take.
Thank you, Cathy. Dee.
We're all going to say stigma. So, but I would also, I've a few years ago took to not saying stigma anymore. I say discrimination. It's truly discrimination against people who use substances. We look at equitable access in mental health, equitable rates of reimbursement through Medicaid, equitable access to services is just not there. So I think it's discrimination. That is the biggest barrier. It's as a person in recovery, I feel it every day. I get super mad when people are making decisions about the people that I've cared for 32 years and that are part of my family. It's not just me. My husband's in recovery. My oldest son's in recovery. It's like my cousins have died. Like, it's like, nothing about us without us. And that, I can't say that any stronger. There was a meme a couple of years ago, maybe it's older, but I only saw it a couple of years ago. It's like, what is super cool if you're rich, but really awful if you're poor? Speaking two languages, doing hard drugs, having other people take care of your kids. Like, it's just not okay if you're poor. And so that's the other thing I want to remind people, is that this is a war on poverty. This is a war on ethnicity, on culture, and not just about substance use, because if you were a millionaire and doing all these things, it's totally fine.
Yeah, so this is when I wish to be first, so I wouldn't have to say stigma the third time. But I will add to the stigma conversation because being in the field for more than a decade, we hear that word a lot. And I've recently heard a presentation from a parent who has lost their child to an overdose talk about stigma. And he shared that, he shared this example, and it just really, it really spoke to me, so I will share it here. That when there is a family in the neighborhood who has a child who has a cancer diagnosis, the neighbors will bring casseroles and will take care of your other children and will do all the things to help you that you would expect when a tragedy hits your household. When you have a household on that same street and you're a parent who has a child who's struggling with addiction, folks will avoid you, they will blame you, they will likely say, what is that father or mother doing? Why is that child struggling? What is wrong with that family? And you are not getting the casserole. So, you know, it just, I don't, like the language is there. I hear about stigma a lot, but it was a really great reminder to hear him describe it in that way, that we still, it's internalized, it's on the system, it's on a macro level, on the internalized level, on the community level. So certainly that is our biggest barrier and very difficult to address, right? Like, I don't know, with all the things that we do, that is like the one thing, other than the media campaign, we really struggle with the stigma stuff. Connecticut specific, we do have some barriers in terms of our quiet corners. I think we call them quiet corners. We have the Northeast and the Northwest that are more rural. That's always, we hear from the community that they often feel overlooked because we do have strategies and initiatives that are usually focused on a lot of the overdose hotspots, the bigger cities. So that tends to be a barrier in some of the work. And also, we've been hearing a lot about workforce shortages, addiction specialists, and then stigma comes up again because the non-specialists and even specialists really not understanding some of the nuances of the work and how to treat people with addiction.
Thank you, Luiza. I want to comment on stigma. This hasn't been mentioned too much today, but as if the stigma associated with the disease is not bad enough, it is really discouraging to see all the stigma associated with the medication for the disease. And it's just mystifying to me that we don't have a lot of tools in our toolkit to help people, but methadone and buprenorphine happen to be arguably the two most effective. Methadone's been around for, what, 50 years. And I'm not saying they're perfect. And I support people who, if they want to achieve recovery and want treatment but don't want medication, we support all journeys. But that's what, did you see Dr. Knapp's slide? Do you remember this? This is just stunning information that you are less likely to die of an overdose if you continue to use than if you're in an abstinence-based facility. Now, there'll be some people that were here, maybe you are still here, who will really be offended by that, because there is people feel very strongly about this, but that is the science. That is the science, and that's why we have now 15 OTPs in Maine, and why we're prescribing. We have 5,500 people today on methadone, the most we've ever had, and we have probably 18 to 20,000 people on buprenorphine. And it won't be lost on Dr. Steele that slide that Dr. Knapp had that showed the people smiling because they were offering buprenorphine in the emergency room. We have been trying to do this in Maine for 6.5 years. It's in Executive Order 2, February 2019. Every emergency department, all 33 in Maine, expected to do this. We're getting there. We're getting there. But you need to, if you're associated with your hospital, you go to your local hospital, find out whether they're equipped to do buprenorphine for people who walk in their emergency room with an addiction. And if they're not, then you call me, because then I'll call Dr. Steele and we will take care of this. What else was I going to say? Oh, the other barrier that I thought you would mention, and it's different than stigma, and that is breaking down the silos in the various levels of government and procurement. I mean, it's really hard to work in government and go through, because half the people think that we don't do enough competitive bidding and don't like to have a sole source contract. And the other half of the people are still waiting for a contract after 14 months and wonder where their money is. So that's been, as a person that's new to state government, that's been the biggest frustration to me, and it's a big problem to fix. I read recently, I'd seen a summary of a book called Why Nothing Works by Mark Dunkelman, who is at Brown. And I said, well, that really speaks to me, because, it just seems like we can't get out of our own way sometimes. People give us the resources, and we can't get it to you to serve the people that we're supposed to serve. And it's a fantastic book, so I recommend it to you. My next question, and as we wind down, and then we'll see if any of you have any questions. This is probably the last one that I'll ask. How might the current initiatives of the Trump administration impact the work in your state, particularly with respect to the reorganization of SAMHSA, changes to Medicaid, things we've talked about today? Anything unique in your states that you're worried about? And this time we'll start with Dee, so we're not always going in the same order.
Yes, well, we're probably all worried about the same thing. I think the Medicaid cuts and access is top of mind, but I'd like to tell you a story. So as the single state authority, I have a trade organization called NASDAD, which is the National Association of Substance Addiction Directors, something like that. Anyways, and so all of us meet in DC, and we just met in DC for our annual meeting, and this is from all the states that are allowed to come. Some states aren't allowed to come or don't have money. And we had the new SAMHSA acting director there. And they said some pretty inflammatory things. So I was up at the microphone going to ask about the combination of the SUD block grant and the mental health block grant. And basically this person who is now in charge of policy, who has no policy experience, none, who is an ANF, who is in recovery, yay him, got in recovery a long time ago and is abstinence-based, went to an abstinence-based program and believes in abstinence-based, basically said, we will not allow states to even use their own money to pay for needles, for clean water, for crack pipes, that's what he was calling them, not safe for smoking supplies, was very much race baiting. And basically, the more that I was defiant in that, the more he became slightly threatening that Massachusetts was going to lose their money. You know, that's very, very scary. So it's beyond what just happened in that bill is that, and this person in their keynote speech at this NASDAQ conference with 400 or 500 people was touting, you know, the best president ever, our great president, Donald Trump, da-da-da-da-da. So already I'm having panic attacks. I've been going to this meeting for 6 years. Not one person from Kansas has come up and given me a hug. I got more hugs from places like Kansas and Idaho and Iowa, and how they were just, and because the other thing was like, it was Pride Week, and they were talking about, you know, you can't mention Pride and say, or Pride Month. And it was just, it was so infuriating. But what really made me sad is when those people from Kansas and Idaho and Iowa and some of those red states came up and they said, we've already lost everything. This just reinforced all of that stigma and discrimination that was already happening. They feel empowered. The youth surveys that they give out for youth to find out if they're depressed or anxious and these things, they're not even doing them anymore. They're not. So we are not going to even know the effects of anything on our children, right? It's beyond the bill of what just came out, which is horrifying. And I think we've gone through it several times. Your Medicaid director was fantastic in kind of laying it out. But I think it's the philosophical emboldenment, I don't even know if that's a word, of just tyranny. That's what really worries me.
That's another good book on tyranny by Tim Schneider, I think his name is. Luiza.
So a lot of this feels really chaotic. You know, I think on my level, it affects our contracts, it affects how, you know, and Medicaid obviously will, Medicaid cuts will obviously affect folks' access to behavioral health. But also the reorganization of block grants, the erosion of grants possibly, it just creates a lot of chaos. Things are late. We already have procurement laws that are long, take time. If we don't hear back from the federal government whether we are or are not getting a grant, it takes longer, so that in turn creates gaps in service potentially, unless our providers trust that we eventually will pay them. So yeah, no, also worried and like I started the conversation, it feels chaotic.
Yeah, it's hard to, when you work for the government, you believe that government can be a positive force in people's lives, and we're trying to help people, to have so much directed at getting people to hate the government, to think that we're just completely, you know, useless and can't do anything and are wasting people's money. It's tough. It's tough, but we're not going to go back. You heard me subtly say a couple of hours ago, we're so lucky to be in Maine. Before turning it over to the audience, is there anything that you'd like to share with us that we haven't talked about the last hour? Any of the three of you? Anything you'd like to bring to our attention, or anything you'd like to say? And then I'm going to see if there are some questions left.
I do. Oh, sorry. Just want to mention that sitting here in the room today, noticing your relationships with folks, Gordon, I just want to mention how important relationships are, and it's kind of a great reminder as a clinician, because I started out the working individually with people, and it was always all about the relationship, and no matter how macro the job gets, it's still all about the relationships, which is just this realization that I wanted to share today.
Thank you, Luiza. It is all about relationships. Dee, anything?
No, but that was really nice, and I should have said it. Sorry, you're amazing. Like we said this before too. This has just been great to it just feels so comforting to be in a place like Maine and listen to Rhode Island and to listen to Connecticut, like just to know that, and to North Carolina for Dr. Dasgupta, like it's heartening because sometimes I know I feel very alone, you know, and fighting an uphill battle, or like the image I have is I'm in a hole and I'm going like this and the sand keeps coming in, right? And I can't get out of that hole. So I think that's it. It's just, it was very heartening, but I agree. We've all been talking about how lovely you are as a host. So thanks.
Well, Maine's not going back. I can tell you, we're not going to go backwards. And so we're lucky to be here with the leadership that we have. Cathy.
So I want to reiterate everything that, I don't need to repeat it, that my colleague said. One thing to kind of end on this is, like, we need to keep doing this as states, right? And bring other states that are willing and interested in joining us. I know that even before the tyranny, because I didn't speak about that. I could tell you, I do want to say that in Rhode Island, we're actually doing contingency planning. I'm not saying that it's going to solve anything, but we actually have a whole framework that has been put together that we're prioritizing against all our states. We've been working on this for a couple of months. But coming together as New England states is what I think, in continuing to have these conversations, because I love what Massachusetts and Connecticut and Maine are doing, and I want to share whatever positive we have or lessons learned with you all. And I just think that would be the one thing that I would hope for. And I think that, Gordon, you're the person to really help us do that, because Gordon comes everywhere. He comes to Rhode Island all the time. And I'm like, how do you drive like 3 hours and just come hang out with us? But we really, really are happy that you come join us. And I'm sure you do the same for our other states. Thank you.
Well, there's 2 grandsons on the way, and that's kind of, not that I wouldn't come without that, but it does help get me to Rhode Island. Well, we've still got over 100 of you kind of spread out here, and we can do another 10 minutes before we dismiss and get the facility cleaned up. And we can get somebody to run a microphone out there. We can use Director Squirrel if nobody else is around. Was there a question? Yes, yeah, we'll bring you a microphone, and thank you. Oh, there's a micro. Well, that can be a live mic. Yeah, we can use that. Yeah, that's a good idea, because you're so spread out. Why don't anybody that's got a question come to the mic? Yeah.
Let's see. It
Thanks.
does work.
Yes.
Hi, everybody. Thank you so much for being here. My name is Dr. Katie Spencer-White. I'm the CEO of one of Maine's 5 low-barrier shelters and homeless services agency, and the only one in central Maine. I am very grateful to the Maine Recovery Council, who gave us life-saving funding last year that is now in our accounts and keeping us open this year. My question for you all, and it's something that has really frustrated me for a very long time, is that healthcare and housing are so bifurcated. In our shelter, we've worked really hard at implementing harm reduction, all the things that you talked about in terms of having centers where people can go. We're doing all of that, and in the last 2 years since we rehabilitated our bathrooms and put in some really cool tech, we've reversed almost 100 overdoses. So when I think of the 1,000 lives saved, and I know that 10% of Maine's population of people experiencing opioid addiction are unhoused, I'm like, we're there. Gordon, we got you. We did it. My question to you all is, I just did a quick Google search of all of our states' rental vacancy rates, and we're all sub 3%. We have no housing. We have a broken housing market. But for some reason, we always leapfrog over the shelter system. Well, we know that people who are experiencing addiction are 5.5 times more likely to die of an overdose when they're unhoused than our housed population. And even when we balance for poverty, right, that unhoused factor is really critical. So I'm curious to hear from you all how you're leveraging shelter capacity, if you are, and if you are not. Why are we not using our why are we not holding our shelters accountable, particularly shelters that are funded through HUD grants? And the state has some influence, certainly, in terms of how those shelters in particular might operate.
I can I'll let Dee talk about what they're doing really well in Massachusetts. So I can tell you that in Rhode Island, when I was actually at the Department of Health, I worked very closely with my colleagues, because I don't talk about this much, but I actually sat on the continuum of care in Rhode Island for like 5 years, and I did a lot of housing work. I used to be a housing outreach for Housing First. So what can be done is to put that directly in the contracts and make sure that you have an actual evaluation that that's happening, right? And it sounds like you're doing that. In our state, we do have shelters. We don't have enough for the amount of people that are experiencing homelessness. And I would guess that probably 90% of them are people who are using drugs, and that's why, because they can't even get into our shelter systems. But there are a couple of low barrier shelters that do exist right now. And just ensuring that every single staff person is trained, educated, and has access to naloxone. And also, it's really important to have relationships in those municipalities with your first responders, mostly EMS, because if you don't, then they're just gonna start being overwhelmed. And I say all this because I don't know if you all know, a couple of years ago, we had what we call the Cranston Street Armory, and we opened it up in the winter because we own it, and it's huge. We had over 200 people in a very small state a night come into that space, not one fatal overdose. We made sure that we had additional ambulance companies there, because there were a lot of overdoses happening, but nobody died. And people were actually, they were able to get to where they needed to get and have better outcomes. And I think the most important thing for our state is, it was the first time ever the emergency department had somewhere to discharge people. So I advocate about that a lot.
Yeah, that was a great question. So in Massachusetts, we don't oversee the shelter system. It's another executive office called Housing and Livable Communities. And when I was a clinician, and things have changed, people didn't want to stay in the shelter. They had to give up their substances. They had to give up their needles. They couldn't come in with their support pet, chicken, dog, whatever. They couldn't come in with their partner. It was dangerous. They were getting robbed. And so people preferred to sleep outside. We've really worked hard to make them low barrier, to get amnesty lockers so they can lock up their supply outside so they feel safe. And so we're really working hard and trying to work with people to understand that the shelter system can be safe. I think there's still stigma with some of the shelter workers, much like Cathy said. The other thing that we're doing inside the shelters, though, at BSAS, the Bureau of Substance Addiction Services, is we've got two really important programs, which is housing stability supports, where people can then get connected to those permanent or transitional housing opportunities outside of the shelter, and T grants, which is, I'm not gonna remember, it's like, treatment, engagement, and assessment grants, so people can also get into whatever type of treatment that they need. So we have T grants and we have housing stability supports. So those are really important things that we're really working on. So.
Yeah, very similar in Connecticut. I don't oversee the shelter programs. And definitely more of a focus with investment into a housing first model for all those barriers for folks who are in active addiction, so that they would have low barrier access. Yeah, no, I don't think I have anything else.
I know you don't have much time left, so in a few words, how would you rate the healthcare organizations, hospitals, health systems, physician and other provider professional organizations, and their engagement in this effort in your states?
I think it varies. I think it's depends. Like we're so lucky we have Boston Medical Center, Mass General Hospital, Brigham and Women's Hospital. We have these big hospital systems that are really wonderful, but we find that it's inequitable where you live, and it's inequitable if you're in Western Mass or Central Mass versus Boston versus the South Shore. Through our opiate settlement money, we invested in 15 hospital programs and 24 hospital locations to create addiction consult services or bridge clinics within these 15 hospitals that they're in each region, right? So then we would have specific care. If you had a heart attack in a hospital and you're admitted inpatient, a cardiac team, consult team would come and meet with you, right? So if you're having an acute event such as an overdose and you're in the hospital, why wouldn't you have an addiction consult team come in and talk to you? And we also know that the people that end up in the emergency rooms, they're seen last. They're sitting there for 6, 7, 8 hours. Nobody wants to see them. People are mean. Some of our hospitals are like, come back when you're sober, or your drinking is not an emergency, or, you overdosed last night, you can't come back. They're treated horribly. So having these bridge clinics with the buprenorphine, which is all required. We also, we really rely heavily on the 72-hour rule around access to methadone. So but I think your results may vary depending on where you are.
Yeah, there's variability. I would add that not just in how hospitals respond, but there's just some clinicians who have that fire in their belly and are really interested in the work and will spearhead having mobile units and be the prescribers on wheels. And then there's others that still need a lot of convincing, and stigma still gets in the way with providers, not just the community.
Is this a trick question? No. So in Rhode Island, we have 24/7 buprenorphine hotline. So we actually have a couple of really big champions in our Brown. It's now Brown Health, our largest hospital system. So we're very grateful, and we have that. But that is like more of a call line, and it just happens to be within our hospital system. We do have recovery coaches that go into all of the hospitals across the state. So that's an option. But that's patient choice. So if the person doesn't want to see a recovery coach, then, they're not going to be called in. So we still have some of the infrastructure we had pre-COVID. But what I would say is workforce is probably the biggest issue in our systems, in our primary care, in our hospital systems, in all of our provider systems. In Rhode Island, and I don't know if it's in your states as well, but I know in Rhode Island that we have a workforce shortage. And that is what's really creates that burnout, that compassion fatigue, which is all part of stigma. It doesn't mean it's okay for there to be stigma, but it's real. When you have compassion fatigue, even people with lived experience have compassion fatigue, and they're leaving the workforce now. So to say I can't score it, I do agree that it varies because we might be small, but we have hospitals across all our regions. Some hospitals are better than others, and our ones in our urban core cities are usually better, except for our northern core city. That might not be better because it's always so packed all the time. So that's what I have for that.